Hey, good morning. Thank you so much for joining us today, and we have many attendees online. So it's a true pleasure to present Dr. Podoltsev today, who will be delivering our grand rounds focusing on CML. Many of you know Nikolai very well. He has been actually around almost 30 years. I was looking at his very long history here at Yale, starting from research and then going into faculty in Saint Raphael after the residency and then fellowship here, and then as a medicine attending, which clearly explains his excellent medical knowledge, as any of you who have interacted with him would know. And then he continued here as a fellow, after which he joined the faculty. So Nikolai is currently an associate professor of medicine. His practice focuses on the management of acute myeloid leukemia, acute lymphoblastic leukemia, as well as more recently becoming, I think, very well known in the area of myeloproliferative neoplasms, including CML. He's running a good number of trials and has been invited to talk internationally and nationally about CML and myelofibrosis. His expertise includes bone marrow failure, especially aplastic anemia and bone marrow failure syndromes. All of you know that he runs our tumor board very well, again, demonstrating his excellent knowledge. On the research front, Nikolai has been doing a lot of clinical trial work, but also has a big footprint in the COPAR and the Yale Cancer Outcomes Public Policy and Effectiveness Research, where he has, I think, made important contributions in the epidemiology as well as patterns of care and outcomes of hematologic malignancies. And during that work, he actually mentored a number of our fellows who went on, I think, to go and get grants and produce very important papers. It's a true pleasure to have Nikolai on a personal level. I think all of you know Nikolai. He's the most collegial and excellent team worker. I think everybody can attest to how good he is with his patients, and it's really a true pleasure to have him as a colleague as well. Thank you so much, Nikolai.
Thank you, Amr, for this warm introduction. I would like to mention that this lecture is supported by a patient, a grateful patient who contributed some funds for us to run CML lecture every year. And this patient is being managed by Dr. Waji Kidwai, who is joining us online from Smilo Care Center in Guildford, and wanted me to emphasize the fact that the results of good outcomes in this patient and many other patients depends on our collaboration. And so we work very closely with our colleagues from care centers, and if they need advice from a specialist, we're here for them. We understand how it may be difficult for them to physically come to grand rounds, taking into consideration how many patients they see and how many of them have to be canceled. But nevertheless, Dr. Kidwai is out there listening to us, and I think in the format, he's not able to speak, but he just texted me that he is there available, and if there are any questions at the end, he'll be happy to answer. Our patient is David Sturges. So he joined us for the first CML talk last year. This is the second one. Unfortunately, he's not able to be here because of his health issues. This is not related to his CML. But he allowed me to present his case today, and that's what the grand rounds will be centered around, about how he presented and what happened to him, his CML journey. So these are my disclosures, and so I'd like to start from the agenda. So it's not in a specific order, but what I would like to address today is some basics of the CML, which should be good for everyone who is taking board exams, medical oncology, as well as hematology ones. And I'm pretty certain you'll be able to answer all of the questions if you sit through this talk and listen to it. I'll be talking about basics of epidemiology and biology, and me and Sam Katz from Department of Pathology, who is here in the audience, we present this topic every year for medical students together. So I'm going to reuse some of those slides, which I would like to thank him for. And that just tells you how basic it is. So I'm hoping everyone will be able to take home something from this talk. So we'll talk about diagnosis of CML, molecular monitoring, targeted therapies with tyrosine kinase inhibitors, And this is the disease where the tyrosine kinase inhibitors as a class made entrance in our world of hematological and oncological malignancies. We'll talk about operational cure, which is basically CML now is the disease like high blood pressure. If you manage it, if you take your pill a day, the chances are you will not have a problem. You will live normal life and will die from something else. In hypertension, you will prevent stroke and heart attack. Here, you will prevent disease progression to more aggressive forms, accelerated blast phase of the disease. Finally, the newer goal for treatment of CML patients is treatment-free remission. So if taking TKI every day provides operational cure, not taking TKI at some point when you develop deep response after treatment with TKIs for a while, you may actually go into functional cure where you do not really need the treatment and disease is not going to come back. So I'm going to focus on our research, which is about CML in older adults. And are the goals of treatment different to younger patients? Or we will look at real-world patterns of care and outcomes in this group, and then we'll talk about management optimization strategies as they apply to this group specifically. So this is our patient. This is Mr. Sturges. He actually consented to be presented, and I was hoping to ask him some questions if he was in the audience, but this is the summary which I worked with Dr. Kidwai on, and he's at the time of diagnosis, which was now 13 years ago. He was 69, retired naval officer, and he was diagnosed with CML. Like a lot of patients, he actually was asymptomatic at the time of diagnosis. He didn't even have splenomegaly on exam, which is actually reasonably common when CML patients present. So he went to his yearly physical and had a CBC, which showed increased white cell count with left shift, but no blasts. Platelet count was slightly high, 443, and hemoglobin was 10. So he had mild anemia. As the result, he was referred to Dr. Kidwai and had a bone marrow exam, which confirmed the diagnosis of CML in the chronic phase. So he had a FISH test, fluorescent in situ hybridization test, and karyotype. Both showed translocation 922, and molecular testing, PCR test, showed that he has BCR-ABL transcript, specifically P210 transcript. He started treatment on imatinib, 400 milligrams daily, which is standard approach. And unfortunately, within the first 4 weeks of treatment, 3 to 4 weeks after he started the treatment, he was admitted to our 11 North in Smilow with side effects. Specifically had severe rash, fever, and generalized edema. Skin biopsy was performed showing leukocytoclastic vasculitis. It was felt that these findings are related to imatinib. The drug was stopped. He was managed with steroids and diuretics, and unfortunately, he became so disabled by all this that he had to go to rehabilitation facility after this admission. So I see a lot of different patients in clinic. You heard from Amr, acute leukemias, different myeloid malignancies, including MDS, but more and more so, my clinic is seeing more patients with myeloproliferative neoplasms. There are two types of them, and the reason we're seeing more and more of them is because these patients live longer, specifically patients with CML, and I'll try to explain to you today why that is true. So MPN patients are divided in pH-positive patients or patients with chronic myeloid leukemia and pH-negative ones, including PV, polycythemia vera, essential thrombocythemia, primary and secondary myelofibrosis. I can talk about any of these diseases for more than an hour, but I will focus on chronic myeloid leukemia today. So we published this a few years ago now, and we looked at the incidence of different myeloproliferative neoplasms, including chronic myeloid leukemia. And the incidence, as you can see, of CML increases with patient age. At that time, in 2020, median age diagnosed was 59, and it was slightly more frequent in men than in women. Now, for this presentation, I'm going to be using the results which we just published in this review article in April. And updated data shows that the median age of diagnosis actually increased between 2020 and 2024, and now is 66 years old. 70% of patients are older than 55, and the estimated number of new cases in 2024 is more than 9,000 in the United States. So this study is now about 12 years old, and the interesting part to this is prevalence. So what is estimated from the standpoint of how many CML patients will be living? And based on the calculations done now 12 years ago, it was estimated that in around 2050, the prevalence will reach plateau and will be about 180,000 patients living in the United States at any given time, taking into consideration their longest survival, which is almost normal now in the TKI era. as well as incidence of about 5,000 a year. Now the incidence is now more than like 9,000 or more a year. So that number is probably underestimation. So what are the common clinical features we see at the time of the presentation for the CML patients? Not most of them, about a third of them, like our patient, will be asymptomatic, just showing some CBC abnormalities. As I said, it is increased white count with left shift, sometimes few blasts, thrombocytosis, anemia. These are common CBC findings which are discovered during physical exams. Fatigue, weight loss, fevers, and night sweats, so-called B symptoms, are seen in some of the patients, and abdominal symptoms related to splenomegaly. Some degree of splenic enlargement, not to the degree you see on that coronal view from the CAT scan, is seen in most of the patients. And in about half of them, the spleen is significantly enlarged to the degree where you can feel it on exam, which you actually have to do and measure if you're taking care of those patients, because our prognostic model, which we're using to select first-line treatment, is based on spleen size in centimeters below left costal margin. So the biology of this disease became more clear in the last 50, 60 years. But in 1960, it was discovered that CML patients have this translocation 922 by two scientists in Philadelphia, hence the name Philadelphia chromosome. And ultimately, we figured out that this is about BCR-ABL fusion. So the ABL proto-oncogene and break cluster region. So ABL is located on chromosome 9 and break cluster region is chromosome 22. When there is exchange of genetic material, you end up having a new BCR-ABL gene on chromosome 22. And this is so-called Philadelphia chromosome. As the result of this rearrangement, a new protein, oncoprotein, is being made, BCR-ABL protein. So the testing allows us to establish presence of this translocation, which is quite helpful in clinical practice. And the fastest in our institution is FISH, fluorescent in situ hybridization. So this result comes back usually within 24 hours after we submit the specimen to our cytogenetic lab, which does an excellent job helping us to get the results even on the weekends when it is necessary. So you can see that the smaller cell is actually normal and the bigger cell is actually abnormal. And the fluorescence shows two signals, green and red, and when they merge, yellow. And so the merger is actually BCR-ABL fusion. So we do PCR testing to detect the type of fusion we're dealing with. And you can see that depending where the break cluster region breaks, we can have P190, P210, and P230 protein as the result. In CML, most commonly we see P210, and less frequently we can see P230. P190 is something we see in acute lymphoblastic leukemia, which is kind of interesting because you have the same translocation leading to different phenotype of different type of leukemia. In fact, acute lymphoblastic leukemia. So the CML is a myeloid malignancy. So we'll talk a little bit more about this on the next slide. So, but what happens when you have BCR-ABL oncoprotein, it oligomerizes, and as the result, the tyrosine kinase activity of this protein leads to phosphorylation of the substrates. And you can see that this may lead to increased proliferation, decrease apoptosis, and decreased adherence to bone marrow stroma, leading to circulation of all these white cells we see at the time of the presentation. So imatinib is the first-in-class tyrosine kinase inhibitor, which was FDA approved in 2001, now 23 years ago. What this drug does, it basically occupies this ATP binding pocket, not allowing ATP to connect to tyrosine kinase and not allowing phosphorylation of the substrates. So that is similar to other TKIs, which have been approved since 2001, and now we have 4 of them approved in the frontline setting for management of this disease. So now a little bit more about the natural course of this disease. So before imatinib, disease would start in chronic phase most of the time, and this may last up to 4 or 5 years. Then disease accelerates, the blast number increases, you have 10 to 19% blast in blood or bone marrow, and the accelerated phase may last up to a year. And then blast phase occurs, and this is much shorter phase of the disease where patients die within 3 to 6 months. So interestingly, blast phase may be myeloid. 2/3 of patients who develop CML blast crisis will have myeloid blast crisis, and 1/3 will have lymphoid blast crisis. The question is, why is that? CML is the myeloid disease. It turns out it is about acquisition of the Philadelphia chromosome, which may occur not only in myeloid stem cell, but also in less mature blood stem cell, which may differentiate to lymphoid stem cell. And so you can develop CML, you can develop CML myeloid blast crisis in 2/3 of the cases, and lymphoid blast crisis in 1/3 of the cases, as well as you can develop ALL. So what are the treatment goals in the TKI era? So we, of course, now have potent drugs which may prevent progression of the disease from chronic phase to accelerated phase. So we do want to improve survival of our patients and prevent progression, but also we would like to preserve quality of life. As tyrosine kinase inhibitors may have different types of effects, and they may be on target and off target, the patients who are taking these medications, like our patient, may experience different side effects. So it is important to have different types of strategies trying to avoid the side effects if possible, preserve adherence to treatment, and preserve quality of life. So this is an important trial which led to the approval of imatinib as the treatment for chronic myeloid leukemia. It is called IRIS trial, which compared a previous standard of care, interferon and cytarabine, to imatinib. So the reason why I'm showing this to you, there is no difference between these two curves only because most of the patients crossed over to imatinib from the standard of care arm. What I would like to emphasize here is the 10-year survival. So before imatinib, 10-year survival for CML patients was about 10%. After imatinib, you can see from these curves, it is more than 80%. So one other interesting thing about this trial I would like to highlight is that it actually excluded enrollment for patients who were 70 years of age or older. So not only we have very effective treatment, we also have great way of monitoring this disease, which is reasonably convenient. It's actually a blood test, which we're mostly using. Of course, we can use this test on marrow aspirate, but we don't have to in most of the patients. So after initial diagnostic marrow, most of the patients do not really need to have repeat marrow because of this excellent way of us measuring the amount of the disease in blood. This is PCR monitoring for BCR-ABL transcript in blood. We're currently using international scale. For those of you who remember warfarin, we have INR, so it's international normalized ratio, so we can compare the results from different labs. International scale is our INR for BCR-ABL transcript level. So when patient presents at the time of diagnosis, usually most of the cells, if not all of the cells in peripheral blood, are Philadelphia chromosome positive. So you would expect a decline with effective treatment, which we're measuring as percentage. You can see from 100% on the left column to 10% is 1 log reduction. So when we have 2 log reductions from 100% to 1%, that is equivalent, if we do marrows on this patient, we will see that detectability of Philadelphia chromosome by karyotyping which usually analyzes 20 metaphases. We will not see any Philadelphia chromosomes, and that is complete cytogenetic response. So 2 log reduction from 100% to 1% using international scale in peripheral blood by PCR is equivalent to complete cytogenetic response in the marrow when we're using karyotype to see how many metaphases are Philadelphia chromosome positive. And this is the most important value from the standpoint of accomplishing improved survival. Further reduction in the BCR-ABL transcript level, let's say from 1% to 0.1%, so-called major molecular response, will add a little bit to survival, but not as significant as accomplishing the level of complete cytogenetic response. So the deeper response is when we reduce the number of circulating Philadelphia chromosome positive cells further, MR4 meaning 4 log reduction or 0.01% by international scale, or MR 4.5, which is the level of detection for our tests, are called deep response. And these are the patients who may become candidates for discontinuation trial and functional cure, treatment-free remission. So NCCN guidelines help us to understand the milestones. The PCR test in blood has to be done every 3 months during the first year. And based on what we see in the blood by PCR, we may need to adjust what we're doing. So at 3 months, ideally, patients have to have less than 10% BCR-ABL transcript, if not by 6 months for sure. And by 1 year, it should be less than 1%. If those milestones are not met, NCCN offers you a certain action plan. First of all, to make sure that patient is adherent to treatment. Second, looking drug-and-drug interactions, which may reduce the effectiveness of the treatment. And finally, development of resistance through acquisition of ABL1 kinase mutations. And one of the mutations you need to know for board exams is so-called T315I mutation, which makes your Philadelphia chromosome positive cells resistant to all first and second generation TKIs. Fortunately, we have third generation TKIs to use in the circumstances, but basically the conformation of the protein, BCR-ABL protein, is such that first and second generation drugs cannot penetrate it to occupy that ATP pocket I showed you earlier. So first generation imatinib was approved in 2001. Since we had second generation drugs approved, as well as now 2 third generation drugs, which are not used in the frontline setting at this time. So, but there are 4 drugs which are approved for frontline treatment of CML, including imatinib, then nilotinib and dasatinib in 2010, and the latest bosutinib in 2017. So this table compares trials which looked at second generation TKIs, comparing them to first generation TKI imatinib. So these landmark studies which led to approval of these drugs in the frontline setting. So first of all, before we talk about the results, I want to you to look at the population of patients which was addressed by these trials. And I'm specifically pay attention to 2 things: the age of the patients, as well as cardiovascular comorbidities. So decision trial, which used dasatinib against and imatinib, the median age diagnosed was 47. They reported that 8.5% of patients were older than 65, and they excluded patients with so-called serious cardiovascular disease. ERNEST-ND, nilotinib against imatinib. So here, 2 doses of nilotinib. It is taken on the empty stomach twice a day, is a 300 or 400. Median age, again, 47. They did not report how many patients were older than 65. And again, they excluded patients with so-called impaired cardiovascular function. Finally, before is the study which compared bosutinib and imatinib, and median age diagnosed was a little older here, 53 up to the age 84. So patients 65 and older were close to 20%, so a little bit more than in the INDECISION study. And they did include patients with cardiovascular disease and reported 11.7% of the patients enrolled on the study having CVD. So now looking at the results and the outcomes. And so I would like you to pay attention to 12 months major molecular response rate. So when BCR-ABL transcript drops down to less than 0.1%. So as expected, second generation TKIs are more potent, and you can see that the number for MMR at 12 months is about 40 to 50%. When you look at imatinib arms across the studies, the major molecular response more like in 30 to 40% range. So it's definitely less. But then if you pay attention to the last row, 5-year survival is the same for both second generation tyrosine kinase inhibitors and imatinib. Of course, second generation tyrosine kinase inhibitors help you to get to deeper responses faster and more frequently. And that may be helpful when you're considering treatment for remission discontinuation trial. So when we decide which drug to use in the frontline setting, we have 4 options now, including first generation imatinib and then 3 second generation drugs. We use this calculator, ELTS score calculator, which helps us to understand the risk of the disease. This is the risk of the progression to accelerated and blast phase. And I plugged in our patient who didn't have palpable splenomegaly. This is his age, and then his platelet count, and he comes up as low risk. So based on this NCCN guidelines approach, we divide patients based on their risk to low risk and intermediate and high risk groups. And low risk patients, there is strong recommendation to use imatinib. You can see that there is an asterisk there, which basically tells you that imatinib may be preferred for all the patients with comorbidities such as cardiovascular disease. All of the second generation drugs are also category 1 based on excellent data. So if you move to the right, looking at higher risk patients, their second generation TKIs are preferred. But imatinib can still be used. And the category, when it is not mentioned by NCCN, it's a 2A as a default. So certainly stronger evidence for use of second-generation TKIs, stronger preference to use second-generation TKIs, but imatinib can still be used. So we will look into the evidence behind imatinib recommendation for all the patients with cardiovascular disease. But, so what I want to do now is to focus on this box here, treatment consideration independent of risk score. What else are we using to select the treatment? So age, comorbidities, toxicity profile of TKIs, and possible drug interactions. So age is one of the, in one of the more obvious scenarios may be considered as an indication to use second-generation TKIs for younger women who are planning to have children, because TKIs are teratogenic and ideally you don't want to use them during pregnancy. So you want to bring a young woman with CML to the time when she wants to become pregnant, perhaps in treatment-free remission, and that is better accomplished by second-generation TKIs, which give you deeper responses faster and more frequently. So we'll return back to the age. Let me talk about comorbidities. So comorbidities can certainly affect your choice of medications. And this is specifically important for patients who are older because they have more comorbidities. This is just an example of a few: cardiovascular disease, obviously, lung problems, arrhythmias, QTc prolongation, diabetes, and pancreatitis. So when you're looking at second-generation TKIs, some of them are more known for their certain side effects. They're more potent, but they have more significant side effects than imatinib, which we're going to see in a little bit too. So cardiovascular disease is something you may need to consider when you are planning to start nilotinib. The risk of cardiovascular events, or so-called arterial occlusive events, is relatively high with this drug. But the highest is with ponatinib, the third-generation TKI. So also nilotinib has this black box warning for QTc prolongation, which I actually think is the class effect for all of these medications. But specifically for nilotinib, it is necessary to obtain an ECG before you start the treatment, and then when you change the dose or you add different medications, which may be QTc prolonging. Also, nilotinib increases glucose, basically can affect your diabetes control and is known to increase risk of pancreatitis. Dasatinib, on the other hand, is something you may consider not using in patients who have lung disease due to high incidence of pleural effusions. At the end of 5-year observational decision trial, about a third of patients develop pleural effusion, and the study unfortunately stopped at that point. But we believe that the incidence of pleural effusion continues after that period of time. Now, looking a little bit more at arterial occlusive events, and this is a very nice summary table from recently published review on this issue at Blood. This is the summary from landmark trials, which I already presented. It also included clinical trials for third-generation TKI, which I didn't talk about, including PACE trial for ponatinib and ASSEMBLE trial for asciminib, our newest third-generation TKI. So to just highlight a couple of things here. So I already mentioned that the nilotinib is associated with significant risk of arterial occlusive events. If you look, I have to give credit to the company. They ran the study for 10 years. And the incidence for patients who were on 300 milligrams twice a day, there were 2 doses there, 300 and 400, was almost 25%. 400 milligrams twice a day, 33% arterial occlusive events, so certainly high rate. So the ponatinib is associated with high rate as well at 5 years, and that's how much data we have. It was 25%. So these are certainly the drugs which are associated with higher incidence of arterial occlusive events, and you may want to avoid them for use in patients who are older with cardiovascular risk factors, or those who already have history of coronary artery disease, for example. On the other hand, if you look at imatinib, in this, it was a comparator drug on the nilotinib trial. You can see here the incidence was at 10 years was 3.6%. You would say, you may say that imatinib has nothing to do with this, and it may be just a background number of arterial occlusive events you can anticipate seeing in this patient population. So this is the meta-analysis of vascular occlusive events, 10 randomized studies. It does not include asciminib here, but you can see that, whatever is on the right from one is associated with the worse arterial occlusive events or vascular occlusive events when compared to imatinib. So the only drug which did reasonably okay in this analysis is bosutinib, which is on top. So everything else, you can see that, everything else, including, so this is for dasatinib, this is for nilotinib, and this is for ponatinib. Everything is sitting on the right side. So certainly imatinib over time, and now we have more than 20 years experience with this drug, showed to be not as offensive to arteries as some other tyrosine kinase inhibitors. So this is the summary table comparing side effects of second generation, third generation TKIs with imatinib. And you can see in green is what is better with second generation TKIs. So, hence it is worse with imatinib. So imatinib is known for superficial edema. It is known for things like nausea and vomiting and rash, as well as musculoskeletal pain. Some of this side effects occur at the beginning of treatment, but then will dissipate with time. So, but what is seen in more potent second and third generation TKIs are other significant side effects, like pleural effusion, for example, here with dasatinib, or arterial occlusive events, which we see with nilotinib and especially ponatinib, or liver function test abnormalities, which we see with bosutinib and with nilotinib. So it is important to mention financial toxicity, and a lot of older patients on Medicare have challenges to pay the copays for the drugs, which cost a lot of money. And all second generation tyrosine kinase inhibitors cost a lot, so this is the price, $10,000 to $20,000 a month. So imatinib is now generic, and there are more than 10 generic preparations of that drug. It became generic in 2016. So the difference in price is staggering. So you can basically buy imatinib for less than $40 a month without insurance. This is comparing to second generation TKIs and third generation TKIs, where this measured in thousands of dollars. So that is certainly something we're considering when we're having conversations with our patients about using different medications. So drug-drug interactions, I think, not as important as everything else, because to me it is easy to discontinue certain of this certain drugs. A lot of patients are in favor of using herbal medicines, and there's some data about drug-drug interactions between herbal medicines and tyrosine kinase inhibitors. But most of the time when I ask our pharmacists to run the drug-drug interaction list, they basically tell us that there is not enough evidence. And there is not enough evidence, we don't know what to tell. I usually tell patients to stop those medications when they start TKIs. So some of the medications may decrease exposure, and this is an issue for all second generation TKIs because they require acid to be well absorbed. And patients who have GERD, Barrett esophagus, and they need to be on PPIs, and that may decrease absorption of second generation TKIs. So here, I try to stop this medication. I try to use less potent inhibitors of acid production. So, but I hope you're not going to fall asleep. I didn't press any buttons. The issue here that some patients still, they are not able to stop these medications because of the severity of their symptoms. And in that case, we have great ways of monitoring this disease by PCR. So I know that if a patient is taking those medications, there is less absorption of a TKI, and BCR-ABL transcript is decreasing, is increasing. So I know we have to change something, either change the TKI or take down the acid-suppressing medication. So some of the drugs actually increase exposure, including amiodarone, diltiazem, and verapamil, azole antifungals, and some herbal substances, and other drugs may be important because of the QTC prolongation, and EKG monitoring may be necessary when these medications are used concurrently with TKIs. Bleeding risk is higher in patients taking dasatinib, and you may decide to use another TKI if you have an option when patients are on anticoagulation for AFib, for example. So back to that NCCN approach to management of the CML, I would like to focus on age part now. So I've mentioned that in younger patients, perhaps it is more important to use second generation TKIs to accomplish treatment-free remission. But, so I think in older patients, this may be an important goal as well. So in general, the older patients have been underrepresented in clinical trials, which I showed you. So, and we did the work with SEER Medicare with the help of Cooper Group, Cancer Outcomes Public Policy and Effectiveness Research Center at Yale. So we use SEER Medicare data set provided by Cooper to study patterns of TKI use, molecular testing and TKI adherence, as well as predictors of TKI use in older patients with CML. So all of these patients are 65 or older. So I'm going to present you some of these results. So the first study was to look at how TKIs are used by older patients. And as you can see in blue is use of imatinib. Obviously, with introduction of second-generation TKIs, they started to play more role in the frontline setting. So this was 810 CML patients who have received TKIs for CML, and the median age of diagnosis was 75. So imatinib was the most used TKI, but use of this drug decreased in first line between 2009 and 2015. So this is looking at other lines of treatment. You can see that about a third of patients had to switch from the first line drug, either because of intolerance or because of resistance or disease progression. We could not say. So about 18% of them, about 20%, when the time came to start the third line treatment, went back to imatinib. So what it tells us is that some of these patients who initially were started on imatinib felt that the drug is not good for them because of the side effects. But when they tried the second generation TKI, they realized it can be worse and went back to imatinib. So this is my favorite Sankey diagram. Without going in details, this is describing what's happening with monitoring for older patients, how the PCR test for BCR-ABL is used during the first year of treatment. So the optimal testing we defined as 3-4 times during the first year. Actually, we have to use it every 3 months, but we gave some leeway here. And so what we realized after looking at SEER Medicare data is that about 20% of patients had no molecular monitoring whatsoever during the first year. So the optimal monitoring was seen in about 45% of patients, and others received suboptimal monitoring during the first year after CML, after treatment initiation for CML. So interestingly, it translated in difference in survival, and patients who were optimally monitored survived longer than patients who were not monitored at all. So the last study I want to share with you is actually the study looking at initiation of treatment. So you presume that now we have 4 different drugs, before perhaps a little bit less, but nevertheless more than one. So this is the period of time, again, between 2007 and 2015. All of the patients will have a try with TKI. So it turns out that in this study, we showed that 25% of patients diagnosed with CML never received treatment for it. So this study, of course, was patients who were older, 76 with median age at diagnosis, and 35% of these patients were 80 or older. So we followed them up to 10 years. Median follow-up was 2.6 years. So then we looked using multivariable analysis. We looked at predictors of TKI therapy in this group. And what we realized is, of course, that patients who are older were less likely to be treated. And then patients who are not married were less likely to be treated. This is actually a common finding in cancer field. People who are not married, they do worse. So, and, so we found that the use of TKIs increased over time after diagnosis of CML, and people who had better exposure to healthcare, including those who are vaccinated against influenza and those who had any kind of low-income subsidy, were more likely to be treated. But the bottom line is significant number of patients didn't receive any treatment, and these are mostly older patients. So to summarize our findings on our patterns of care for TKI use, imatinib is preferred TKI, and about 20% of patients who switched off imatinib went back to imatinib because they realized it is not so bad. So molecular testing is optimal. Only about half of the patients and about 20% didn't receive any molecular testing during the first year after initiation of treatment, and lack of testing was associated with poor adherence to TKIs, as well as decreased overall survival. So finally, looking at TKI's use in older patients with newly diagnosed CML, we realized that a lot of them do not even try the TKI, and it was more common not to see treatment among older patients and less common among patients who have better access to healthcare. So back to our patient. So Mr. Sturges started dasatinib after discharge from rehab facility. In 3 months after starting this drug, he was in major molecular response. BCR-ABL transcript in his blood was less than 0.1%. In 6 months, he accomplished deep response, in fact, complete molecular response. He had less than 0.0032% BCR-ABL transcript level in his blood. This is the level of detection for most of the conventional labs. So he continued with BCR-ABL monitoring afterwards every 3 to 6 months and remained undetectable. 10 years later, after diagnosis, he presented to Dr. Kidwai with shortness of breath and dyspnea on exertion. Imaging showed moderate right pleural effusion. Dasatinib was held. He received diuretics. And after improvement, he was restarted on a lower dose dasatinib, 50 milligrams. So unfortunately, the symptoms recurred. He also had quite a few other things going on with him, including mild anemia, diarrhea, GERD, kidney stones, osteoarthritis, and vasomotor rhinitis. So not all of them are attributed to dasatinib, but Dr. Kidwai reached out to me. We discussed the case, and we decided that it is a good time to stop the tyrosine kinase inhibitor. So this is our discontinuation trial with hope that patient can enter treatment-free remission and functional cure. So this happened in 2022, 10 years after diagnosis, so 10 years after he went into complete molecular response. And 2 years later, which is now, he is off treatment. So a lot of symptoms got better. It turns out that you do not really appreciate how much you're losing when you're on some of these medications from the standard of quality of life, which you can only appreciate after the drug is gone. So his shortness of breath, dyspnea on exertion resolved, his anemia resolved, diarrhea went away. So also some of the joint pains also went away. So we recently published this article on management of CML in older patients. And I think I'm most proud of this table, which Jessica Stemple, our third-year fellow, helped me to create. So this is how we can optimize the treatment with TKIs for our patients. And it is specifically important for older patients with CML. So because they have more comorbidities and they are more predisposed to suffer from different side effects. So on the left is the standard dose, and then there is an opportunity to dose modify even before you started the treatment. You can start from a lower dose. This is specifically true for dasatinib, the drug our patient was on. You can start in 50 milligrams. And there's a Japanese study actually looking at 20 milligrams. It works for Japanese patients. We, of course, cannot extrapolate this data on everyone else in the world. So interestingly, imatinib can also be dose adjusted, but usually this dose adjustment is after you start the treatment. It is so-called de-escalation, and it can be due to toxicity. So you can go down to 300 milligrams from standard dose 400 milligrams. Going to 200 is actually losing a lot on efficacy, so I would not recommend to do that. So there are some other helpful hints here how to treat patients with second-generation TKIs. For example, for bosutinib, the dose on frontline setting is 400 milligrams, but apparently in older patients, doses as low as 200 to 300 may work. And also, there is a way to dose escalate this drug to avoid GI toxicity. It is known for nausea and diarrhea. So ponatinib, our third-generation TKI, which is very helpful when we take care of patients with T315I mutation because it is able to penetrate the changed BCR-ABL protein structure, is very well known for arterial occlusive events. You remember at 5 years, the incidence was 25%. So the new type of study was organized to figure out what's the best way to optimize the use of this TKI. And the outcome here is BCR-ABL less than 1%, which is equivalent to complete cytogenetic response by 12 months in a year. So there are 3 strategies: 45 milligrams when you reach 1% by or less with BCR-ABL by PCR in blood. You can go to 15 milligrams. So the strategy is similar, but the dose beginning is lower, 30 milligrams to 15 milligrams for the second group. And finally, the third group started from 15 milligrams and continued with 15 milligrams. So the best strategy based on this study is to start from 45 milligrams, which gives you the most efficacy and comparable toxicity to 30 milligrams. Unfortunately, the toxicity is much less or less, well, not much, but less in patients who are taking 15 milligrams a day. But, the effectiveness is, of course, suffering here as well. So that is an optimal strategy. Now you start from 45, and then as soon as you hit 1% of BCR-ABL transcript in blood, you go to 15 milligrams. So again, it's in the second, third, mostly third-line setting, patients with T315I mutation. Going back to the discontinuation study, NCCN guidelines as well as ELN guidelines have a description when it should be considered. So the longer you're on a TKI, the longer you're on deep response, the higher the chance that after discontinuation, you will remain without detectable disease in treatment-free remission. So at the minimum, you have to be on a TKI for 3 years, and for 2 years, you should be in deep response, MR4 or better. The PCR testing at the beginning has to be done every 4 weeks, and then every 6 weeks for the next 6 months. And after a year, it is every 3 months long-term. Most of the patients will have increase in those who, and it's usually 50-50 for patients who adhere to this particular parameter. So 50% will remain in treatment-free remission, 50% will have to be restarted on the TKI. Most of those who restarted during the first year after discontinuation. Interestingly, if you stay in deep response longer, like our patient, he was in deep response for 10 years. So the chances to be treatment-free long-term are higher. So if it is 2 years, it is 50%. If you're in deep response for 5 years, it's about 80%. So the one aspect of this is, again, financial toxicity. Some of my patients prefer to stay on imatinib and not discontinue it because they pay more in co-pays for BCR-ABL testing than for imatinib itself. So this is hypothetical model of what happens with 100 newly diagnosed patients with CML. 90 of them will have chronic phase, 10% will present an accelerated and blast phase disease. So among those 90, about 2/3 will be able to get to deep response with first or second generation TKIs. Those who go in deep response and stay there for at least 2 years can try discontinuation with goal of treatment-free remission. But as you know, if after 2 years of deep response, it's only 50-50. So at the end, among 100 newly diagnosed patients, only 30 will be able to go to treatment-free remission. And certainly there is room for improvement there. We know that the longer you take the medication, the TKI, the higher the chance that you will develop side effect. This is true for dasatinib and pleural effusion. This is also true for arterial occlusive events on nilotinib and other TKIs. So ideally, you want to get them off because that's the way to preserve quality of life. And that is the way to avoid side effects. And hopefully it can work for more patients than just 30 out of 100. So we need new drugs. And this is an exciting development in the field of CML management. So this is asciminib, first-in-class BCR-ABL STAMP inhibitor. What STAMP is standing for is specifically targeting the ABL myristoyl pocket. So this is the publication from New England Journal of Medicine, which contained the picture. It's not common to see the picture of that nature in a research article, but it explains to you how this drug works. So first of all, ABL 1 kinase has this myristoyl N-terminal, and this myristoylated N-terminal can inhibit the ABL 1 kinase activity by attaching to the myristoyl pocket. So when you have translocation, BCR-ABL translocation, you lose this myristoylated N-terminal, and instead you have BCR. That's the middle picture. So there is no autoinhibition of ABL 1 kinase, which is now continuously activated. So the asciminib actually is inhibiting ABL 1 kinase activity by attaching to that pocket, as opposed to the ATP pocket, where other tyrosine kinase inhibitors work. So you can see the difference in this cartoon here. So all of the TKIs are attaching to this ATP binding site, blocking phosphorylation of the substrate this way. On the other hand, the asciminib attaches to myristoyl pocket. This is allosteric inhibition of ABL 1 kinase. And even with T315I mutation, which may impair attachment of other TKIs, asciminib should work. So The study which led to its approval is called ASSEMBLE trial. This is the first phase 3 study looking at third-line treatment for CML. And, so this treatment was more effective. The comparison was bosutinib, the second-generation TKI. You can see that primary endpoint was major molecular response at 24 weeks, which was accomplished by more patients on asciminib than on bosutinib. And toxicity was better. So one of the arguments for use of this tyrosine kinase inhibitor is better toxicity profile because there was less off-target activity. It's myristoyl pocket on ABL1 kinase rather than ATP binding pocket, which is present on many other kinases. So this drug was approved in third line based on this ASSEMBLE trial in 2021. So again, it's a third line setting. And I just want to tell you that it is not all that perfect with any of the TKIs. You can still see arterial occlusive events, even on ASSEMBLE study, even on the drug, which has different way of working against ABL1 kinase. 5.1% after median follow-up of 2.3 years. By the way, bosutinib, the comparator on that trial, 1.3%. So this is the phase 3 study, which so-called ASK for first, asciminib in first-line setting, was presented a week ago at ASCO and simultaneously was published online in New England Journal of Medicine. Certainly the path for this drug to be approved and be fifth tyrosine kinase inhibitor approved in frontline setting for CML management. So it was compared to two stratas. One of them is imatinib and another one second-generation TKIs. This is as chosen by investigator. IS, investigator selected TKI. So in the first graph, you can see comparison with those patients who were pre-selected to receive imatinib. And you can see that major molecular response was, the first one is actually all of them, imatinib and second-generation TKI. So 49% in that group, major molecular response, which is comparable to other second-generation TKIs we saw in a table I showed you earlier. Asciminib, impressive 67%, almost 68% after 1 year of treatment, major molecular response. The second graph on the right is comparing to imatinib. And here, again, no surprises, 40% for imatinib of major molecular response at 1 year and 69% for asciminib. So it is interesting that there were older patients on this study, about 23%, 24%. Were older than 65 and about 6% were older than 75. So they did well with asciminib. You can see that major molecular response was more likely on those who were treated with asciminib as compared to the other arm. One of the reasons all of these patients were in imatinib because they're older. So people recognize that imatinib is a useful drug for older patients because of its side effect profile. And hence there is such an advantage there, even though the number of patients is very small. So again, side effect profile was more favorable among patients treated with asciminib. You can see that adverse events leading to discontinuation are half in asciminib when compared to imatinib and second-generation TKIs. Also, there is less frequency of adjustment of the dose based on adverse events in asciminib group. And grade 3 side effects were less frequent here as well. They are 3 or higher. So this is the study which we have available for patients here at Yale, with asciminib. This is called Ask to Escalate. This is in second-line setting and amended to have first-line setting as well. This allows you not only use asciminib for patients in second-line setting where the drug is not approved or first-line setting where likely will be approved soon, but also to escalate the dose based on response. The treatment-free remission is not one of the goals of the study, but would presume that, so if you're not accomplishing deeper responses at the beginning, you will have an opportunity to increase the dose and get to them after dose adjustment. So another study I want to draw your attention is something which is designed by Dr. Zaidan, my colleague who presented me today. This is the cooperative group trial, which is looking at addition of pembrolizumab, PD-1 inhibitor to any TKI used in frontline setting with the goal of treatment-free remission. So we want to get these patients to deeper response. We want them to be able to discontinue the drug to avoid any long-term side effects. This study is also open here. So I would like to bring what I discussed to this conclusion slide. So first of all, treatment goals are similar for older and younger patients with CML, improving survival, preventing progression to accelerated blast phase disease, which, by the way, is very difficult to treat, and preserving quality of life at the same time. The selection of tyrosine kinase inhibitors, especially for older patients, is based not only on disease risk assessment, but also comorbidities and drug toxicity profile. Optimal molecular monitoring, as we showed in our study, makes a difference as it is associated with better adherence to tyrosine kinase inhibitors and improved overall survival. Treatment optimization strategies, I argue, are very important for older patients, including selection of appropriate TKI, as well as those adjustments up front or down the road based on toxicities, based on side effects, as well as based on response. Imatinib is a good drug for older patients based on its toxicity profile, but also dose-adjusted bosutinib and perhaps dasatinib, which, by the way, is going to become generic sometime this year. And we may be able to avoid some of that financial toxicity I was talking about, are good choices for all the patients. Finally, asciminib. We probably have to give this drug a little bit more time because it's relatively new, even though people argue that it has been in use in different studies for about 10 years now. But it is certainly a reasonable third-line drug. If I choose between ponatinib and asciminib for my T315I mutated patient who is in the 70s, I would go with asciminib. And treatment discontinuation with the goal of treatment-free remission is something you have to consider for patients who are in deep response. It can be accomplished by older patients, even though you may think that this should be a goal for younger patients who are expected to be on treatment longer. Still, for older patients like our patient I presented today, that was the way to overcome significant side effects. And he remains in treatment-free remission now 2 years after discontinuation. Thank you. So before I finish, I just want to acknowledge a few people. So David Sturges, our patient who is supporting this grand rounds, and Waji Kidwai, who is present virtually. Funding for our studies by Frederick A. DeLuca Foundation, as well as our Yale Copper Group, Carrie Gross and Pamela Solis, and my colleagues who participate in Hematology Copper Group as listed here. Thank you very much.
Thank you so much, Nikolai. A great talk. We can take a couple of questions. Yes.
Thanks, Nikolai. That was terrific. In lung cancer, we follow a lot of the lessons from CML with our TKIs. And at ASCO, we had a plenary presentation that talked about the LAURA trial, which is adjuvant TKI or consolidation TKI after concurrent chemoradiation. And there was a benefit of about 35 months compared to placebo and a hazard ratio of 0.16. So again, learning from you that you continue, and actually in that trial, it was continuing osimertinib indefinitely. So my question looking at the de-escalation is really, have you characterized those patients? Have you characterized the exceptional responders? Because obviously, if you could figure out who those patients are, then you could de-escalate earlier than 10 years. Or is it just lack of resistance mutations?
So, of course, CML is a very different disease, and I wish we had the same outcomes among other patients with different malignancies whom we're managing with tyrosine kinase inhibitors. So, there were a few things which were looked at, and, one of them is the type, for example, is the type of the transcript. Patients with P210 transcript, which is the majority of CML patients, are doing much better than patients with P230 transcript. And so they, would be the candidates for discontinuation. We never discontinue for patients who at any point were an accelerated or blast phase of the disease, right? So because they showed us by their biology. And if patient progressed on the TKI and now is using another TKI, we also don't discontinue. So there are some other things which, I've mentioned that the longer you are in deep response, the higher the chance that after discontinuation, you will not relapse. So there was a Eurosky study update published in JCO, I think this week, basically telling exactly the same, that if you're on the medication for a longer period of time, and especially if you're in deep response, your chances to be treatment-free after a while are higher.
So if Nikolai, I have one quick question. So I think the best thing about real life research, this kind of outcomes research is sometimes that there's a huge disconnect between what we do in trials and real life. And I was actually stunned that 25% of older adults are not getting TKIs, which are extremely effective, very safe. And you have to wonder how much of that is financial considerations. I think this was before the generic.
Yeah.
And, I think Mark Cuban is like really starting, I think, a very interesting
$36 a month,
approach
Mark Cuban
with
Pharmacy,
this.
everyone.
So do you think this number is going to change
So we're actually
substantially?
planning to study it. Thank you for asking. So this is on our table to look at, so we finished our study in 2015 and imatinib went generic in 2016. So we want to redo our study and look what changed, because financial toxicity is certainly one of those things which may be important when patients make this decision. Obviously I showed access to care, age as being other factors, but I think you're right. Financial toxicity may be an issue, and perhaps now we'll see better numbers.
Especially with the generic dasatinib, I think that would be very interesting.
I don't need the mic, I'll just shout. Okay, just to follow up on that.
For people on Zoom.
So for the patients who didn't get treated, where there was a difference between married and unmarried, is there a
Yes.
is there a gender interaction there?
I don't think we
It's
found
just the
gender.
unmarried men who don't
Yeah,
get
well,
treated?
so it's usually unmarried men, right? Who don't do as well. I think that was shown in different types of cancers, and these publications and JCO, if you want to look it up. I don't think we found, we found gender difference, but I mean, need to look again.
Married men do what they're told.
That's right, and that usually means they take their TKI and they go for their monitoring, right?
Can I ask one, Nikolai? It's this beautiful science of TKI, but do we know what triggers CML? What incites this B variable?
So, like in a lot of cancers, we do not really know. I mean, so it is, for example, the atomic bomb survivors in Japan, they have higher incidence of CML. There is a clear connection there. So, but beyond that, there's not much known about, why certain people develop it and others don't.
Yeah, this is always, I think, a very important question. I think you mentioned this patient, the patient was a veteran. And
Yes,
certainly
that's
we
right.
have
I
seen
didn't,
like
I
in
didn't
MDS.
explore his exposures in the Navy. Yes.
Yes.
Like, have you figured out what's cut off for accelerated phase or blast phase? What's the most recent update you have for that?
So I think WHO decided against separating accelerated and blast phase. So they're just talking about advanced disease, but I'm still in favor of separating them. And I think ICC, there are two classifications we're using for hematological malignancies these days. So ICC still recognizes the accelerated phase. And usually it's, there are a number of different criteria. There are MD Anderson criteria. If you look at the ICC paper, it's basically 10 to 19% blasts. There are additional karyotype abnormalities, which are used also to put these patients, in addition to Philadelphia chromosome, you may have second Philadelphia chromosome in the same cell or some other abnormalities that will put you in accelerated phase as well.
But does the PK make a difference?
So, right, so if you're diagnosed with accelerated phase, you treat this at the same way you would treat chronic phase. And I do have patients who do well, right, who do respond. And, so it's different when you actually develop accelerated phase while you're on TKI treatment. When you progress on one TKI to another, your outcomes are much worse.
I think this is part of why they eliminated it, because it's essentially the same management as long as you get a TKI and it's not on top of the TKI, as Nikolai was saying. Okay, if there are no other questions, thank you so much.
Thank you very much for being here. I thought it was educational.